Are you looking for world-class health and wellness advice combined with a dose of inspiration and spiritual encouragement? You've come to the right place. This is nourishment for body and soul. This is Manna, and I'm Dr. Turner. Welcome. Well, hello friends. This is Dr. Turner. I hope you've been enjoying this series with Dr. McCullough. We're back now for part 2. It was a fascinating conversation. I enjoyed it very much. A privilege to get to know him. And I hope you're gleaning some important and lively and insightful information here from this discussion. So here we go with part 2, and hope that this will bless you today. Take care.
We are having a convo with Dr. Michael Turner. He's young, he's handsome, he's athletic, and boy, he is a terrific father and committed to his patients, physical medicine and rehabilitation. But Michael, you really became a medical doctor during COVID. It sounds like you really did everything you could to help your patients.
Indeed, Peter. I say that actually I felt more alive, more invigorated, more dynamically involved with my profession and more in the role of a healer than I've ever felt at any other time. I wonder if you feel the same way, but it was an eye-opening and extraordinary experience for me to really try to step in to be all that I could be as a physician.
No doubt about it. The last several years have been the most rewarding of my life. Sometimes I feel like I'm a character in some type of action movie or spy novel or something going on. You know, I'm a cardiologist and internist, but people say, well, you know, you're not an infectious disease specialist. I said, I am now. I mean, you know what I mean? We've done so much. And in a sense, we have kind of gone a little bit, in a sense, outside of our scope of practice, or better stated, we expanded our scope of practice to manage this. Now, how did you also expand your scope of practice in physical medicine rehabilitation to include some of the integrative aspects of medicine, which really now are becoming of high interest and popularity?
Yeah, well, I had an interest in health and wellness all along. I was raised by a mother who was very health-minded. She was, somewhat in the realm of the hippie movement and such. She went to Cal Berkeley in the late 60s. She worked at a natural food store. So when I grew up, for example, we couldn't have sugary cereal. TV was greatly limited. We were encouraged to play outside, to read books. We had dinner every night at the table. I was never allowed to have video games. So I grew up with a mind that was already, you could call it integrative in its approach towards, health and wellness. And then I think a second pivotal experience for me was in high school. My basic public high school health class was really very eye-opening because we were studying about the eye and the heart and the lungs, et cetera. And I just felt like it was as if the hood of the car were being lifted, and I could see all the inner workings. And, we live in our bodies, of course, but how self-aware are we? And this was the fascination in the Middle Ages when they finally started to do autopsies. As you know, in the history of medicine, autopsies had to be done surreptitiously. People had to sneak into cemeteries and such because there were prohibitions against, opening up the body like that. But there was a whole new world underneath. And that's sort of what I felt like going through high school health class. And so I started running, lifting weights, eating better and such like that. So that was my integrative focus. It was just really personal. And then in my professional realm, I set out to essentially share what I was doing personally, which was, I'm obsessed by the question, what would it feel like to be as healthy as I could possibly be? Right? That's my driving question. I'm kind of an overachiever and a perfectionist. And I just got obsessed with this question. What would it feel like to be as healthy as I could possibly be? I'm not trying to be as healthy as somebody else over here, who's a professional athlete or goes to the gym every day. I'm not trying to be as healthy as my 27-year-old self, but how could I be as healthy as I could possibly be at my age? Am I doing that? And if I were to do it, how much better might I feel? What would the return on investment be for my professional life, my business life, my mental acuity to help my patients, et cetera? So I always had this continuous improvement mindset. And as I went through medical school, I never felt like I was signing up to only deliver medications. That wasn't the oath that I took. The oath was to help the patient. Right? So in my mind, I'm always thinking my job's to help the patient the best way I know how. And maybe that means a medication to lower their blood pressure. And maybe it means they need to put some blueberries in their smoothie every morning. And maybe it means they need to go get their colonoscopy. And maybe it means they need to start doing Tai Chi to work on their balance and their fall risk. And maybe it means they need to go get that blood sugar lowered with some more aggressive medication. And maybe it means they need to start intermittent fasting and improve their insulin sensitivity and take some nutraceuticals to stimulate AMPK pathways, etc. So I never felt boxed in that I could only give one type of answer. I was always looking for the most helpful approach that was most applicable and most cost effective for my patients. And I felt like it was my duty, my job, my moral responsibility to go find that wherever it was and bring it and serve it up to my patient.
Okay, great. So what I want to do, that was actually really good. What I want to do is I want to present to you an imaginary patient, and I want to hear what you would give as initial brief dietary advice.
Sure.
Okay. So with just as you would do it, no dietitian, no nurse, just you, and they're asking for brief dietary advice. So it's a 60-year-old male who's 5'8" and weighs 260 pounds. So he's obese, and he's had a total hip replacement just about 2 months ago, and he's gone through the hip replacement rehab. He's still working on that, and he's been told that his weight contributed to his degenerative joint disease. He has some in his knees and his ankles and his other hip right now. He is a type 2 diabetic, and he's on metformin, and he has hypertension, and he's on an ACE inhibitor and a diuretic. And he doesn't have any coronary heart disease, and he has normal kidney function, normal liver function, normal electrolytes, and he eats an unrestricted diet. So he would ask you, he said, listen, I'm in trouble. I just haven't been paying attention to my weight or health over time. Dr. Turner, you look like you're in such wonderful health. You're a wonderful role model. I could never look like you did, but how can I get better? What would be your brief dietary advice?
Sure. First thing I would mention would be to try the idea of intermittent fasting, or at least paying more attention to the chronology of when he eats. And that is to say, getting in sync with your circadian rhythms and getting in sync, therefore, with things like insulin ebbs and flows. And so I talk to patients about the idea of an eating window. So an 8-hour eating window being like 10 a.m. to 6 p.m., for example. Even a more strident eating window would be a 6-hour eating window. Again, let's say noon to 6 p.m. The beauty of this, as you are well aware and probably have spoken about, and Dr. Jason Fong, for example, is all over the internet talking about this. But the intermittent fasting stimulates insulin sensitivity for sure. And also, people will start to lose weight even without changing the composition of what they eat, right? If they can just eat what they eat in a different time range, the weight will start to come off. And it's particularly important, I would tell him, that you front load your calories towards daylight hours. The way I tell people is, a McDonald's hamburger at 1 p.m. is not the same as a McDonald's hamburger at 10 p.m. Okay, not even close. It's hormonal.
So just stop there. So insulin, so this idea of using intermittent fasting to in a sense start to leverage the hormonal balance without a lot of technical details, because most of our listeners are not doctors, they're lay people. But this idea of intermittent fasting, that's completely different from the old advice of eating little nibbles, kind of eating continuously through the day. People used to say, don't let yourself get hungry. Was that all that old weight loss advice? Was it all wrong?
I don't think it was all wrong. No, Peter. Many people did lose weight doing that. But as physician scientists, we want to be open to evolve and to stay up with best practices and best understanding. I think some people that can work well, but if you can manage to move yourself towards the intermittent fasting zone, it's preferable. I would say it's more potent. The way I describe it to people is, look, when you go to sleep, okay, you eat your last meal, you eat dinner. Your body's digesting those calories. They wash through your system, let's say over the next 3 or 4 hours. Sometime in the middle of your night, your body shifts to fat burning mode. Okay, because you still have basal metabolic rate. You still have to burn a certain number of calories to keep the lights on, so to speak, as you're sleeping and run all the central physiologic processes. So when you wake up in the morning, your body is already in fat burning mode. So here's the kicker. Why stop that by putting something in your mouth? The moment you put something in your mouth, your body shuts off fat burning mode and goes to dealing with what you just provided it. Instead, run with it, accentuate it, let it, that fat burning mode roll out as long as you can into that next morning. And in fact, accentuate it by doing cardio. So this is where I describe an exercise component coming in. I tell people, skip breakfast, leave your fast going until 10, 11 a.m. and instead do some cardio in the morning. Again, cardio in the morning on an empty stomach is not the same thing as cardio late in the day on a full stomach. Just as a hamburger at 1 p.m. is not the same as a hamburger at 10 p.m. So I try to just get the chronology a little bit different. That tends to be a great first step because number one, people notice results. Number two, they don't actually have to eat anything differently, right? I'm not telling them you can't ever eat steak again, or you have to stop putting salad dressing on your salad, or stop putting creamer in your coffee. I'm just saying, let's just shrink up the eating window a little bit and give time for your body to actually burn fat. So that would be dietary principle number one. I think the next thing I do is I talk about the concept of a low carb / low sugar diet. Again, I take my cue a lot from eminent people like Dr. Robert Lustig. I remember when I watched his video, Sugar, the Bitter Truth, it was an internet phenomenon, got tens of millions of views, which was, in my mind, sort of ironic and striking, but also a sense of pride because here he was, an academic physician, giving a community talk at UCSF, School of Medicine for probably 40 people in the audience. It was like their Wednesday night, professional talk or something, and all of a sudden it becomes an internet phenomenon, but with very good reason. So in that video, he talks about how sugar is basically a metabolic poisoning, especially fructose. It's terrible for the liver, messes up insulin levels, etc. So I talk about the principle of a low carb / low sugar diet, and I put it out like this. I say, essentially, your body has two different fuels it can burn for energy, carbs or fats. It could also burn protein, but it doesn't like to do that. Obviously, protein being a structural component of your muscles and your bones. So unless you're starving to death and catabolizing yourself, you're not going to burn protein. So your body wants to exist in either burning fats or burning carbs. Now, fats actually have more energy per unit volume than a carb does. And so if you can switch your body into fat burning mode, you're going to end up burning more energy, and you're also going to have a more sustained energy source. Again, I use the metaphor of a carb would be like lighter fluid. You're hitting your fire with lighter fluid, and fat molecule would be like a dense oak log that you put on there, right? And so I tell patients, if you are eating a lot of carbs, your body switches from fat burning mode to carb burning mode, which is exactly the opposite of where you want to be if you want to lose weight. Whereas if you starve your body of carbs, in quotes, to a degree, right, it shifts away to fat burning mode. And by the way, as it shifts to fat burning mode, you end up with more steady energy source, and you don't end up with these ups and downs of feeling tired, etc. I mean, how many of us have had the feeling? I certainly have, Peter. I would go out to breakfast, with a friend, and sort of in a moment of indiscretion, have 2 pancakes, 3 pancakes, and maple syrup, etc. And then I'd want to fall asleep, a half an hour later at 8 a.m., I just feel sluggish and want to go home and fall asleep. Has that ever happened to you?
Yeah, I've always been curious about two things. One, clearly pancakes and waffles, and this idea of you want to fall asleep an hour or two later. And the other thing is eating Chinese food and a massive amount of rice, and then you're hungry an hour or two later. Let me just tell you what I do on brief advice, so you can see how different it is. You get into a lot of the science and everything you described. I do it a little bit differently. I say that someone like him, the patient I described, his goals is he wants to lose weight, he wants to improve or resolve diabetes, he wants to reduce his risk of heart disease. And so because there's multiple goals, there's no single diet that's published that really works that way. So people say, well, what is this? Is this Atkins diet? Is it Sugar Busters diet? Is it South Beach diet? I said, no, it's everything. Actually, the whole goal of diet is to be eclectic with everything. And so what I tell people is that, listen, with respect to weight loss, that about 80% of weight loss is diet and 20% is exercise. So exercise needs to be there. But people who are obese, if they just exercise alone and don't change the diet, essentially the weight doesn't change. So I said before that, so it's 80% diet, 20% exercise in terms of the determinants of weight loss. And then among diet, that one needs to make healthy choices and have portion control, both. So it's very important. So if you just make healthy choices, but the portions don't change, then there's no weight loss. So then in healthy choices, what I boil it down to is what do people need? So they need high quality sources of protein, and all sources of protein are about the same in terms of the polypeptide. What the difference is the package. It's the package in which the protein comes. So I say high quality sources of protein in this order: fish, beans, nuts, egg whites, non-fat dairy, and then occasional lean meats. That means occasional chicken, pork, and beef. Occasional. It doesn't mean chicken every day. People think it's chicken. No, occasional. And then fresh fruits and vegetables are unlimited. So then now that makes it easy. So what should you get rid of? The 3 S's. The first one is sugars, sweets and treats. Second one is starches, anything made out of flour. That means all the baked goods, and then potatoes and rice. And then people immediately start to negotiate. I said, listen, starch and sugar molecules linked together. You don't need any of it. None of it's needed. It has no essential amino acids, no essential fatty acids, not a good source of fiber, not a good source of vitamins. You do need no starch. And then the last one is saturated fats. And saturated fats nowadays is pretty easy. So it's burgers and fries, pizza, and gooey cheese. So and I tell patients, listen, I live in Texas. I'm not a vegetarian, but if you can go 2 days a week vegetarian, that's terrific. So when people do that, I tell them, listen, that's just healthy choices. That's just healthy choices. Now you need portion control. And then portion control, then we start to work on it. What's new for me is intermittent fasting. I used to teach that, you have small meals and you don't get excessively hungry, etc. The intermittent fasting, I've really started to become convinced. And what I've found for myself, Michael, and what I find for most people is they're not very hungry in the morning. I think most people honestly could skip breakfast. Most people maybe crave a cup of coffee, but they can skip breakfast. And so the most available intermittent fasting would be, let's say you stop eating at 7 o'clock at night, just go ahead and take it all the way around to about, noon or 1 o'clock in the afternoon. And so again, the eating window is 6 hours. And, I give patients brief advice in the office. I do it verbally. I explain it to them. And, and I used to have a 1-page handout, but I think it'd have to get to be that simple. And, I realize in the dietary literature, about 60% of all calories in the United States comes from starch. And I use the word starch. I don't use carbs because people get confused. They think an apple, while both have some carbohydrate in it, an apple is very different than a muffin, very different. And what I've told people is, listen, I've never seen somebody come in my office obese because they eat too many Macintosh apples. I've never seen it. I've never seen it. People come in obese because they eat way too many muffins and bagels and buns and cookies and crackers. That's where it's coming from. 60% of the diet is starch. And as soon as that starch gets out of the diet, the caloric intake plummets.
Right.
And people just can't eat enough apples to make up for it. I don't, you could sit and basically have enough chips, and you could just keep eating chips and chips and chips. In fact, or Cheetos or Doritos, and keep going and going, because you eat one and then you want more. But when you eat an apple, you say, that was good, I'm done. Another good, and I think people need hunger control strategies. Another thing I do, like today, I was hungry and I was seeing patients in the office, and I went back there. I was talking to one of the girls in the office. I said, I need some hunger control. You know what I reached for? I reached for just a few walnuts, shelled walnuts. Best hunger control. And she goes, well, I'm hungry too. I said, here, just try a few, chew them good and swallow them. And then ask yourself in a minute or two, are you hungry? And it's amazing. I had those walnuts now, gosh, right now it's about 8 o'clock my time. I think I had the walnuts at like 3 in the afternoon. It's really taking care of my hunger. Wow. So anyhow, we all get brief advice. We just have a few minutes left. Michael, what I want you to do is just, why don't you tell our audience, since you're pretty big out there in social media and your practice, to tell our audience how they can learn more about you, how they can find you, how they could potentially be a patient or a person who follows you and learns from you.
Oh, well, thank you. Sure, Peter. Well, Substack would be the primary way. So Dr. Turner, drturner.substack.com. There I publish health and wellness articles and also put up my podcast episodes. And then the podcast specifically is called Manna, M-A-N-N-A, Manna with Dr. Turner. It's on Apple, it's on Spotify. Would be happy to connect with people. Right before we end, if you still have a chance, Peter, I would love to go back to your question there about the vaccines. We didn't quite get a chance to talk about that, but I'd love to hear your perspective and chat about that a little bit.
Well, we just have a minute or left. Well, why don't you tell us what do you think? Do you advise your patients to take COVID-19 vaccines?
Most people no. I almost never do, because the risk-benefit ratio is not favorable for almost all demographics, essentially. And I started to become suspicious of them through studying the spike protein, right? And I would encourage the audience, if you want to do your own research, just enter the search term COVID spike protein or SARS-CoV-2 spike protein and tell me what you find. And it's all very negative. The SARS-CoV-2 spike protein has very negative physiologic effects. And then just realize, my question was, well, does the vaccine create the same exact spike protein? Is that what we're talking about? And the short answer is yes. In fact, worse. Everything the SARS-CoV-2 spike protein can do, the vaccine spike protein can do, and more. And when I realized that, I said, my gosh, we're putting in the most toxic part of the COVID virus, arguably, and we're instructing ourselves to do that. And we're creating widespread volume of distribution through lymph, etc. This is a disaster. And that was the beginning of me really questioning that.
Okay. Well, I'm at the same point. You probably know I've advised in the U.S. Senate to pull them off the market. So I'm unlikely to go back from that. Listen, Michael Turner, thank you so much for joining us on the McCullough Report. This is going to be a wrap for this show. And I can't wait to connect with you at the meetings coming up and out there on the circuit.
Indeed. Thank you so much, Peter. It was a pleasure. Enjoyed the conversation very much, and look forward to connect with you again.
Let's get real. Let's get loud on America Out Loud Talk Radio. This is the McCullough Report.
This wraps up another edition of Manna. I enjoyed our time together, and I hope that this has inspired you towards a healthy and happy life. Be blessed.